and I'll let the participants know.
It is our pleasure to present to you on behalf of the International Psychogeriatric Association, our new webinar, Substance Use Disorder. IPA is and it's not IPA, there are more organizations under IPA, and here they are, you can read on our activities. I want to say something about IPA itself. IPA is dedicated to mental health of older people. It's world's leading multidisciplinary global psychogeriatric association. We are from the task force on webinar series. I have the pleasure and honor to chair it. I'm Myrra Vernooij. I'm a professor at Radboud University Nijmegen. And I'm organizing this together with my colleagues, Professor Maria Lapid, psychiatrist from Mayo Clinics USA, Dr. Rob Medan, psychiatrist from Toronto, Baycrest, Toronto in Canada, and Christian Tranley, the IPA program manager. The IPA series originated during the first COVID-19 lockdown. And we have a special format, meaning that we are very much dedicated to the discussion. So you are very important as participants. And this time we have, usually we have two presentations. Here we have two presenters, but they do a duo presentation. They present together. And we are dedicated to one subject in order to promote a more in-depth discussion. And your questions are guiding us in the discussion. And the questions, I ask you to put your questions in the chat. Because it's too difficult to do it by hand raising, if possible, we can also do that. But please, if possible, put it in the chat. The webinar is about global patterns in substance use disorder and strategies for diagnosis and treatment. I want to make some household messages, and the most important one is to put your questions in the chat and to fill in the evaluation afterwards. I would like to introduce the speakers of today. It's Dr. Christopher Kitamura. He is a geriatric psychiatrist at Baycrest, Toronto in Canada. He is an assistant professor. He's the co-founder and co-chair of International Geriatric Mental Health Network and the Canadian Geriatric Substance Use Disorder course for geriatric psychiatry residents. The other speaker is Dr. Marilyn White-Campbell. She is a geriatric addiction specialist at Baycrest, and Marilyn is also co-investigator with the Canadian Coalition for Senior Mental Health, which established 4 national clinical best practice guidelines for substance use disorder for older adults. Christian, can you give the floor to the speakers, please?
Greetings, everyone. Thanks very much, Dr. Vernooij-Dassen, for having us, and thanks, Dr. Madden, as well, and Christian for facilitating today. We're delighted to be here with the IPA, talking about substance use disorders in older adults, the latest buzz. So in terms of disclosures, neither Marilyn nor myself have any conflicts of interest or other disclosures to share. And regarding learning objectives for today, we're going to start off by talking about the global epidemiology and impact of substance use disorders in older adults, discuss some of the barriers to diagnosis and care of these patients. We're going to discuss tools and resources that can be used to support these patients and review some special populations, including substance use in people with dementia and the older driver. Couple of things to note that we won't be covering. We're going to be focusing today on substances. So we're not going to be talking about the behavioral addictions. And as well, we're going to speak mostly about transdiagnostic or universal approaches to older adults with substance use, regardless of what that substance is. Although we will share a few substance-specific pearls towards the end. Now, as you've probably seen in the recent years, there's been a lot more media attention to this area of older adults and substance use. These are all newspaper articles from the past 3 years. See the article on the left from the UN News in 2021 talks about drug use among older persons being the hidden epidemic. And this language actually echoes, for example, the recent UK guidelines that talked about older adults being the invisible addicts. Much of the articles that have been published relate, of course, to drug overdose deaths, often due to opioids, and this is particularly concerning in the older adult age range. The article over on the right speaks to the boomers, and we'll come to them shortly. The next couple of slides, we're going to present some data across the globe, and this is from a nonprofit organization called Our World in Data, which is associated with a collaborative with the University of Oxford. This graph here shows alcohol and drug use disorders as a share of total disease burden as of a few years ago. And what you'll see is this is largely a global issue. Some of the burden is the highest in the Western countries, especially the United States, as you see here, but also some very high degrees of burden throughout Russia, parts of Europe, South America, Australia, and seemingly the only areas relatively spared are some of the sub-Saharan African countries and some parts of South Asia.
We see alcohol and drug disorders deaths have increased worldwide over the past 20 years. We're seeing an increasing trend largely explained in the 50 plus and 70 plus age group. If you look at the yellow arrows, you'll see the upward trend in the 50 to 70-year-old age group. In terms of healthcare costs, if you look at the red bars, you'll see that in Canada, the highest substance use attributable healthcare costs for patient hospitalizations are for older adults. The highest rates are for tobacco and alcohol, likely due to chronicity. There are also indirect costs, including lost productivity, criminal justice, which also account for a large proportion of costs. In the UK, alcohol-specific deaths are higher in the 50s and 60 age group. If you look at the gray bars on the left-hand side and on the right-hand side, you'll see admissions by age, and the rates in the 55 to 75-year-old age group remain high. In older adults, substance use, we're seeing rising rates over the past 20 years. High-risk alcohol use in the US at 20%, in Denmark 32%. Tobacco use, 8% in the US and Australia, and 10% in Canada and the UK. In terms of cannabis use, it's 5.7 in the US, 7% in the UK, and with legalization in Canada, 8%. Sedative misuse, 8 to 17% in the US, and opioid misuse, 1.7 in the US and 3% in Australia.
Now, in terms of why rates have increased, there's really a few different factors. One of them is people are living longer, and with a longer life expectancy, it means that many older adults are using their substances over a longer period, creating more harms, as Marilyn had mentioned. We also want to think that older adults living longer have more coexisting medical conditions, so that polymorbidity creates more risk for harm. And similarly, older adults are being prescribed more medications. So there's more potential for drug-drug interactions, as well as interactions between substances and prescription drugs. There's also, of course, the impact of legislation, for example, legalization, which we'll come to, and cultural and attitude changes over time.
So we see with the hippies, they used the drugs of the 60s to expand their consciousness. But the boomers are now using in later life, and the strains are much, much higher. The THC in cannabis in the 60s was about 2%, and in Canada, the THC levels now with legalization can be quite high, and it's not uncommon to see an older adult using THC levels at 28%, which is 14 times higher than the cannabis that they used in the 60s. So in terms of legalization, we legalized in 2018, around the time of legalization of cannabis, we saw an increase in related ED visits, impaired driving. It's important to note that with legislation in Canada, the trends indicate that older adults are the greatest proportion of new users. We also saw trends including increased ED visits due to cannabis toxicity and motor vehicle accidents, and Chris will touch on that later on. Decriminalization in Portugal was the first country to decriminalize drug use. The results here illustrate the effects of decriminalization. There was no increase in drug use or high-risk drug use. There was reduced drug-related deaths and increased admissions to treatment and reduced overdoses and decrease in HIV infections. We're navigating this in British Columbia and Canada, and they were piloting decriminalization, but the province is now backtracking on this policy.
Now, if we look at the research in this area, and I did this recently, so just searching addictions and older adults as mesh terms in PubMed, we see, fortunately, starting in around the 80s, a significant increase in the amount of published literature. In fact, Marilyn and her colleagues published one of the first textbooks in this area of older adults and substance use in the 1990s. The question remains, of course, what will this trend look like in the years to come? Are we going to continue to see more interest in publications? Is it going to plateau, or is it going to go back down again? We hope not. So there's an opportunity at the present. And what we're seeing is new or updated clinical practice guidelines for substance use in older adults around the world. These are all samples from the past 10 years. We see guidelines from Australia, the UK, Canada, which I'll talk about a little bit more in a moment, and most recently updated United States guidelines. So I wanted to just for a moment speak about the CCSMH, the Canadian Coalition for Seniors Mental Health, which is an organization, a community of practice for all clinicians, and also for the public, an advocacy organization. And one of the things they do is they produce terrific guidelines. Marilyn and I were involved in the guidelines for substance use disorders in older adults, which has been a focus. They produced 4 guidelines on the substances of alcohol, cannabis, benzodiazepines, and opioids, as well as there's a number of great tools for patients and families as well. All of these guidelines are free for download at ccsmh.ca. You'll also find on the website a link to a terrific e-learning module for cannabis and the older adults, so check that out. Now, I want to just take a step back and talk a bit about the neurobiology of addictions. That picture up in the corner is Dr. Nora Volko, who's led a lot of the research and been a public face in this area to really emphasize that addictions, including in older adults, are true diseases of the brain, and that with repeated exposure, there's a rewiring, or what she sometimes called a hijacking of the brain by the drugs. We can think about the actual brain regions on the image on the left, and the process by which an addiction happens in 3 stages, represented by the blue, red, and green, respectively. It starts off with an initial exposure to the substance and that reward and pleasurable response and wanting more. Then there's a withdrawal of the substance, which leads to negative mood states and stress. These are mediated by the basal ganglia and the amygdala, respectively. And then there's a craving and a preoccupation that's mediated by the frontal lobes. And we also see over time with repeated exposure, executive difficulties, executive dysfunction, whereby people are less able to inhibit. And so the pattern repeats.
Psychosocial factors of addiction are trauma, coping styles, personality, supports, or even lack of supports. There are differences in the Asian indigenous cultures and metabolism and tolerance, which is low in these two groups, and this increases the risks for substance use disorders. There's factors associated with substance use in later life, transitions in late life, such as retirement, changes in health, loss of a spouse, isolation, and loneliness. Elder abuse is prevalent with older adults with substance use disorders. Financial abuse is particularly high in this population. And of course, ageism is a psychosocial factor.
Now, just talking about what some of the differential effects of substances are in the older adult in particular. We know there's pharmacokinetic and dynamic changes. Older adults are more sensitive to the substances, for example, changes in sensitivity in the brain. I mentioned increased drug-drug interactions. On the whole, older adults have reduced body water, which leads to increased concentrations of hydrophilic drugs. There's also an increased percentage of body fat, which leads to longer staying around in the body of the lipophilic drugs. We also know that the liver metabolism and renal clearance is slower in older adults. I mentioned the effects of greater medical comorbidity with aging. We also want to think of the effects of cognitive impairment, of course, where older adults with cognitive difficulties, may not be aware of the amount of substance use or the impact of use and be unable to cut down. The table in the right is based on a recent paper from Lehman and colleagues, and it really depicts the many possible signs and symptoms of substance use in older adults. And you can see that the presentation is quite varied. Many of these symptoms here are non-specific, and no one in isolation is pathognomonic for a substance use problem. But when you're seeing changes such as sleep and mood changes, falls and other injuries, malnutrition, impairments in self-care, of course, cognitive changes, and changes in behaviors such as withdrawal from activities, it's definitely something to think of. And down on the bottom right, I mentioned a little bit tongue-in-cheek, substances affect you here. But of course, substances can affect older adults, the whole body, all the systems, all the organs. And when it comes to diagnosis of substance use disorders, in North America, the most prominent diagnostic criteria is the DSM criteria. There's 11 criteria for a substance use disorder, and you have to have at least 2 or more symptoms with evidence of distress or impairment over the span of a year. Just wanted to highlight, as you'll see in this table, some of the unique ways where the criteria may be applied in older adults and actually how they may not fit as well for older adults. I mentioned with some of the physiologic changes, older adults are often encountering harms from lower levels of use, so they may not be using more, and they may not even be using regularly, and they may encounter less issues with physiological dependency, tolerance and withdrawal and the like, or with the withdrawal might look quite a bit milder. Some of the diagnostic criteria refer to role impairment, and we know that the roles of older adults are often different. They've often retired, they may not be driving, they may be living alone now, so they just don't fit quite as well. One of the things I'll mention that was a change from DSM-4 to 5 was the addition of cravings as one of the diagnostic criteria. And from outside of North America, in fact, much of the world, the ICD criteria is the most prominent classification system. The ICD, as you'll see here in the pyramid, identifies a number of different levels of harmful use, from lower risk or lower harm use to the most harmful. The top 2 levels here would roughly map on to what the DSM-5 calls a substance use disorder.
So there are barriers to diagnosis. Does this patient belong in geriatrics, addictions, or psychiatry? As you can see, there's an overlap between those disciplines. In psychiatry, many older adults also have concurrent mental health issues. It's easy for older adults to fly under the radar. Many of the signs and symptoms of substance use mimic age-related illness. There are many biases, gender, social class, culture, early onset, late onset, lack of training in our education system for medical staff, age appropriate and coordinated care and access, research and government policy, and also barriers in ageism. With respect to stigma, there's levels of self-stigma, interpersonal and institutional. There's discrimination in the healthcare system. There's a recent Canadian study which highlighted that opiate agonist therapy for people who were admitted to the emergency department, that older adults are less likely to be offered opiate agonist therapy than younger people. There's ageist beliefs. It's the only thing that makes them happy. This is really false because it's a depressant, and 74% of older adult psychiatric inpatients have a co-occurring mental health and substance use disorder. People their age don't people their age don't do well in treatment. This is false. Older adults do as well, if not better, than the younger people in treatment. They have the stigma of being old with substance use disorders and often mental health and frailty. We can combat ageism by including persons with lived experiences, change our language, using the word substance use instead of rather than addiction, a person living with substance use rather than addict. Screening. As I mentioned earlier, there's a lack of screening tools that are older adult specific, but we do have some. We have the mainstream tools of the ASSIST, the Audit-C, the QDIT, and the CAGE. These are all mainstream tools. The CAGE, for instance, is a yes or no tool. It's brief, easy to use, but it does not invite conversation and can produce a false negative. Using older adult specific tools such as the SMASG and the MASG and the Canadian STAMI tool, Senior Alcohol Misuse Indicator tool, these are older adult specific and have greater specificity and sensitivity to detect at-risk drinking in older adults.
I want to just come over now, talk a little bit about prescription drug use and misuse. And there's use of prescription medications that are clearly appropriate, and there's use that clearly falls under the category of substance use disorders. But I just wanted to highlight there's a lot of shades of gray in between, and there can be misuse or at-risk use on the part of the patient who may take more or less than prescribed or use for purposes other than prescribed or skip doses or hoard. Note that these behaviors may be intentional or unintentional. Also, there can be at-risk use by the physician, including prescribing for inappropriate indications, unnecessarily high doses, and failure to monitor polypharmacy. And there is a good questionnaire out there, a screening tool that's been validated in older adults called the Prescription Drug Use Questionnaire, the PDUQ. So check that out. And we're also blessed in our area that there's a lot of excellent guidance around potentially inappropriate medication use for older adults. You've probably heard of many of these. The US Beers criteria is commonly cited. I quite like the stop-start criteria out of the UK because they identify not only the medications to avoid, but better therapeutic alternatives. Choosing Wisely has operations in many different countries. I mentioned some of the work of the CCSMH around benzos and opioids. There's a really interesting newer program out of Ontario, Canada called GeriMed Risk. It's a multidisciplinary program that provides individualized medication recommendations for older adults with polypharmacy and polymorbidity. And we could talk a bit about that in the discussion. And we're going to talk shortly about brief interventions, but I wanted to share one example here in the area of deprescribing. So this is some of the work of the Canadian Medication Appropriateness and Deprescribing Network. And one of the products that they produce are Empower brochures. There's several brochures for different classes of medications. These are some screenshots here for the Empower brochure around sedative hypnotic use. And these are brochures geared right for patients and families, talk about some of the concerns of use and how to taper and alternatives. And there's been some positive studies that have come out. For example, a study that showed merely giving patients the brochure increases greatly the chances they're going to start a discussion with their provider about the medications. And even just providing the brochure increases from about 5 to 27% the likelihood that that patient will stop those inappropriate medications by 6 months. And the Empower brochures also have some evidence to support their use in people with mild cognitive impairment or mild neurocognitive disorders.
So we have brief interventions, the SBIRT model, the screening, brief intervention, and referral to treatment. And in the US, out of Florida, they have the brief intervention and treatment of elders, the BRIGHT study. They screened 85,000 older adults and identified them as moderate risk and were offered brief intervention and high risk and referral to treatment. There's motivational interviewing, which I'm sure you've all heard about and use, has open questions, affirmations, reflective listening, and summarizing. These are typical tools, but there are limitations to motivational interviewing for cognitively impaired due to lack of insight, and they may not be able to give an appropriate history. So how do you get that information from someone who has no insight or who is cognitively impaired? For alcohol, in Canada, we have low-risk drinking guidelines for the general population and for the older adult. In the Canadian Coalition for Seniors Mental Health, we looked at tolerance and age-related changes in the body, and we cut the guidelines in low-risk drinking guidelines by 50%. So for males, it's 7 standard drinks per week for males and 5 for females with 2 non-drinking days. In Canada, we got very negative press around Canada's health guidance on alcohol, which was based on World Health Organization data, which identifies alcohol as a level 1 carcinogen. So the Canadian guidance on alcohol is a no-risk drinking, and we also have our guidelines are low-risk drinking guidelines. The pause or predictor of alcohol withdrawal severity is a good tool to determine the need for medically supervised withdrawal. There are 2 anti-craving medications mentioned in our guidelines, acamprosate to support abstinence and naltrexone to manage cravings. They're both effective in older adults. The numbers needed to treat for naltrexone are quite low at 11 compared to numbers needed to treat for statins, for instance, which are quite high, and you don't think twice about prescribing those. So it's very underutilized. The use of dealcoholized beverage can be used very effectively in older adults with dementia. There's lots of new dealcoholized beverages on the market that taste like the regular alcoholized beverages, and it's difficult to detect the difference. In terms of cannabis, we recommend in our guidelines to usually avoid it if there's evidence of mental illness, cognitive disorder, cardiovascular disease. There's greater risks associated with higher potency THC levels, and there's possible risks and increase when driving. We need to recognize the signs of cannabis intoxication, for instance, psychosis, cardiac issues, and hyperemesis syndrome. And we also need to look at and assess for withdrawal, because hyperemesis is also a symptom of withdrawal, with consideration to longer and higher dose use. There's no established medications for cannabis use disorder or for withdrawal, but some of these candidates are listed. There's a treatment program. This is a model of care used in Canada. This is Canada's first addiction treatment program, called the COPA program, was established in the early 80s. It's a harm reduction program, low barrier, it's home visiting. And the research from this program indicates that older adults do better in age-matched programs.
I wanted to finish off in the last few minutes by talking about some special populations. So we'll start off by dementia. And it's first important to say that the rates of substance use in people with dementia is not well known. Asking about substances is often not done, and it's not included in many of the BPSD scales, in fact, most of them. There is a number of possible mechanisms whereby dementia may lead to substance use, and this includes impulsivity, impairments in judgment and insight, self-medication of other BPSD symptoms like mood and sleep, of course, medication errors for older adults who are self-managing meds. There are some protective factors whereby use of substances may be reduced, for example, in people where there's access difficulties due to mobility or limited finances, older adults with dementia may be more supervised, or they may reside in facilities which have restrictive policies around substance use. And of course, changes in social milieu and routines. Just a couple of quick tips to support older adults with dementia. Think about capacity to make treatment decisions, such as around anti-craving medications. Also capacity to manage finances to purchase the substances. And as a general approach, we'd like to think of least restrictive approaches. Now, in terms of the link between alcohol and dementia, historically, it's been thought that alcohol is protective against dementia. But we know that with more studies and more longer follow-up, this is not the case. The 30-year running Whitehall 2 study out of the UK found that consumption of 4 or more standard drinks per week was associated with visible hippocampal atrophy on imaging, and that light drinking was not protective for dementia. Similar results out of a 20-year French study found that alcohol use disorders was the strongest modifiable risk factor for dementia and accounted for about half of early onset dementias. In terms of whether they're reversible, well, the good news is that in abstinence, generally the cognitive impairment stabilizes, and in about 20% of people, there's actually some reversal or improvement. And now what about the link between benzodiazepines and dementia? Well, this was a 2018 systematic review and meta-analysis, and the results were pretty clear that the use of benzodiazepines is a risk factor for later development of dementia, with an odds ratio of about 1.4. Although the authors concluded that based on the evidence, it was not possible to say which dementias people were at greater risk for, or if the type of benzodiazepine matters, or the exposure load, the doses and duration. Now, switching over to finish off talking about driving and alcohol, much of this data here is based on out of the US, with research showing that about 6% of US older adult drivers reported driving impaired by either alcohol or drugs, and about half of these explained by alcohol. So about 3% of older adult US drivers reported driving under the influence of alcohol. Interestingly, some evidence shows that of older adults admitted to trauma centers after motor vehicle accidents, about 14% of them had a positive blood alcohol content. And a couple final classes of drugs and effect on driving. There have been no on-road studies of older adults using benzodiazepines and risk to driving, but there has been some studies using simulated driving, and they did find that older adults using benzos had greater difficulties with road positioning and motor vehicle accidents. In terms of the evidence and the literature around cannabis, it's a little bit more mixed. In fact, a meta-analysis from last year showed no increased risk, but shortly thereafter, you may have heard of the US Long Road Study, which is a large study of 2,100 older drivers. And what they found was that past year cannabis use was associated with more motor vehicle accidents and more traffic stops.
So conclusions, we see that globally, older adults are using recreational and prescription drugs at increasing rates. Morbidity and mortality and healthcare costs associated with older adults with substance use disorders is significant. There exists various barriers to diagnosis and treatment of older adults with substance use disorders, and there's added complexity supporting older adults with dementia and older drivers. But the good news is research and clinical practice guidelines in older adults is growing. Media and policy influencers are showing more interest and advocacy. With older adults, friendly services, substance use disorders are highly treatable. So thank you for your attention, and now we have some time for questions.
Thank you very much, Chris and Marilyn, for your great talk, and I like it very much that you shared the talk. What I especially liked, that it was a great combination of biological, sociological information, so great context, and of treatment. So I think that might raise a lot of questions or remarks, and I'm asking you now to put your questions in the chat. So far, I don't see it, but maybe we can also give it a try that you raise your hands. Hopefully you come up immediately.
See a question from Ellen. Marilyn, did you want to take that one?
Yeah, thanks for a great question.
Okay.
The difference in the treatment program for the COPA program was around the fact it was a home visiting program. No one had ever gone out and visited people in their homes. Usually in mainstream treatment, you have to admit that you have a problem, you have to go to treatment and participate in treatment. But with the COPA model, it was a low barrier. We went to their homes and saw them in their homes, and we did not ask them to admit that there was problematic substance use at the very beginning. It was just establishing rapport and looking at ways to support the individual. And usually the alcohol or other substance issues sort of came a few weeks later on in treatment and people started to make their changes around the 3-month mark. The program itself was a longer term, so oftentimes we had people in treatment up to a year and sometimes even beyond. So again, low barrier, and people we saw people that were pre-contemplative, which was unheard of, and it's still unheard of. People that don't admit that they have a problem. But there are, as I said, establishing the rapport certainly made a difference. And the people that participated in the program, we did quite a lot of evaluation. And again, it was about acceptance and looking at harm reduction. And the treatment outcomes were actually quite a bit better than in mainstream programs for this population. About 42% cut down on their substance use and were able to stay in the community. 12% sort of stayed at the same rate, but their health issues were taken care of, and perhaps housing issues, if they were being evicted, for instance, those issues got taken care of. About 16% abstained from the substance and did better in treatment. So overall, we had really good treatment outcomes.
Thank you, Marilyn. The next question is from Sujoy Mukherjee. And the question is, what approach should be taken when people are referred for cognitive assessment who are drinking a significant amount of alcohol? Who can I give the floor?
Good. I can take that one. It's a big problem. We don't see it just related to cognitive assessment. We also see it for people who are referred for psychiatric assessment, right? Or people that show up in the emergency department if they've been using substances. They're all, often, turned away from treatment of those coexisting issues, be it cognitive or psychiatric. I mean, generally speaking, we don't want to refuse services. I mean, that's part of the ageism that we referred to. It is true that you're going to get a more accurate assessment of underlying, brain functioning. It's not, if they're abstinent, it's not quite clear how long that should be. I've heard some reports of 3 months to get back to a baseline, but I think that research is pretty limited in terms of how long it takes after someone stops drinking. And it's unfortunately not something that's clearly addressed in the guidelines as well. I mean, I would like to see a treatment program, even if it's around cognitive assessment, that the referral is accepted. There may be some assessment, at least from history, of the pattern of cognitive changes, and then some ongoing follow-up that includes referrals or support around the substances, and then hopefully reassessment once the drinking has been reduced or abstained. But it's a good question.
In our guidelines, in the CCSMH guidelines for alcohol use disorders, we did suggest that you do a cognitive screening at baseline, and then again at 6 months or 9 months later, so that people can see the changes when they have the opportunity to stop or reduce their drinking, for instance. There can be some changes, and so it's a very hopeful thing to see after 6 months, for instance, that perhaps their MoCA scores have changed and have improved. So that was one of the recommendations of our guidelines.
Thank you. Another question is about a specific study. This study looking at BZP. There is an increased risk of dementia. Was this a cross-sectional association or a longitudinal association? So it's a very specific question.
Yes, that systematic review was those studies were largely cross-sectional, so they were not prospective. So I think that reduces the ability to say that there's a causal connection. I think unlike some of the work mentioned with alcohol and the Whitehall study and the French study, those were longitudinal studies where people were followed for decades. That's a good point.
And here is a rather, thank you, Chris. Here's a rather practical question. How do you introduce Revia in elderly with dementia plus alcohol abuse when competency is partially altered, but you would like to aim at abstinence in order to decrease the impact on cognition and mood?
Yeah. Marilyn, did you want to talk about that?
Yeah, so one of the things is that, again, with when there is cognitive impairment, oftentimes there's a family member or a substitute decision maker in Canada. That's the language that we use. So the person who supports and makes medical decisions on behalf of a person with dementia, and so the medication can be administered. And we have seen many times when someone is very cognitively impaired, the family members start giving the medications and using harm reduction methods such as using a slow taper, using dealcoholized beverage, that the person is able to benefit from the medications. So it's kind of a therapeutic lie, if you will. So family members are there, trying their very best to care for the person in the home, and even though the person doesn't understand and appreciate that they're getting the medication, we see that the results. We see that people are able and have cut down on their drinking. So and again, sometimes we do see changes in the MoCA scores for someone who's has Alzheimer's, though we're not seeing differences, but we're certainly seeing a difference in the alcohol consumption. You asked about gabapentin.
Can I comment on that one, Marilyn? Is that okay?
Yeah.
Okay, yeah. So, I mean, the best evidence is, and what's recommended in the guidelines is naltrexone and acamprosate. The others haven't been specifically studied in older adults. There is certainly some evidence from younger adults, gabapentin, topiramate, to name a couple. But I actually had a recent example of somebody in their 70s who was prescribed gabapentin for pain reasons, went on a sort of heavy drinking binge and ended up in hospital due to profound confusion and sedation too. So something to be mindful of. Gabapentin, perhaps a little bit more proneness to some of the central nervous system side effects, especially if used in combination with heavy alcohol use.
Thank you. The next question is from Anand Ramakrishnan, and I didn't repeat it, but all questions so far started with a compliment and thank you for the great presentation. And so did this one also. In UK, we see that there is more resistance from the community services for substance use disorder in older people. Do you see different patterns across the world? If so, can you give few tips to improve the situation?
I'm happy to take that one. Again, the difference in treatment approaches and treatment programs, and older adults do better in age-matched treatment programs. So low barrier and age-matched can make a big difference. There are some programs in the UK that Tony Rayo and his team worked on, and they again, home visiting and very low barrier programs. I think it's important to make sure that your programs, that the mainstream programs make it accessible for older adults. You have to think about accessibility. I've been trying to get somebody into a residential treatment program for about 9 months, and they can't get a bed because there are only two places in the province that have wheelchair accessible programs. So it's all about how the setting and the treatment approach.
Thank you.
Can I just add one thing to
Yes,
that?
please.
You know, it's important to, I think, understand and try to meet the agenda of the older adults that we're working with, and their main concern may not be their substance use. It may be their at-risk housing. It may be their, you know, very limited income and ability to get food. So programs that really look at the other social determinants of health, I think you're going to have better outcomes and you're going to have better engagement as well. And I think that's one of the things that the COPA program, for example, that was one of their tenets.
Thank you.
So,
I have a question to all of you. I would highly appreciate if you switch on the video. So that's an advantage of this kind of webinars. And now it's just like the speakers and me are there. Thank you. Thank you so much. The next question is from my colleague Maria Lapid. For geriatric patients who have been drinking alcohol for 50 to 60 years and do not think they have problems and have no insight on how alcohol contributes to cognitive impairment and multiple medication comorbidity, how do you motivate them and move them out of the pre-contemplative stage? I think that's a question for Marilyn.
Yeah. Again, the treatment approach that we have used over the years and still use is to, again, focus on the issues that the person's coming into treatment with. Again, Chris had mentioned eviction, for instance, you know, finances, whatever the person is needing some support with. Some of them may not have had any interaction with their family doctor for years, so they may have health issues. And it's, again, establishing the rapport. And so, you know, trying to make sure that they're, you know, that they're comfortable with you, and then moving forward. But again, remember the screening tools that I mentioned, some of the screening tools that are older adult specific. So the SAME, the SMASG, conversational. How has alcohol affected you in later life? And do you prefer alcohol, spirits, beer, or wine? You know, instead of, you know, do you drink, yes or no? So it's again, how you have that conversation. And if you don't ask the question, you're not going to get the answer. So, and again, we worried less about people admitting that they have a problem and more about, you know, them participating and allowing us to come and visit, because some of them were very, very sick when in the first, you know, few years of COPA. Again, the people that we were seeing were very, very sick. But again, we had very amazing treatment outcomes.
mm-hmm. I'll just add one thing, if I can, to that. Just a quick anecdote. I had around motivation and what motivates people. I was working with a patient recently with an alcohol use disorder that was very much attached physiologically, psychologically, and found a lot of comfort from their alcohol. But they were recently in hospital due to severe toxicity, and the most important thing for them was avoiding being in hospital. And also that they were at home and not able to curb their drinking, but they wanted to stay at home without 24-hour supervision, which is what they needed at that time. So we weren't able to make, you know, some of the more nuanced connections, or not so nuanced, between the alcohol and the specific health outcomes. But it was very motivating that if we reduce and stop your drinking, you're going to stay out of hospital. You could keep living in your house, and you may not need to be supervised 24 hours a day. So that was what ended up being compelling.
Thank you. The next question is from Ari Cooperveen. You can see him.
Thanks, Ari. A great question. So it's about the ethics about the dealcoholized beverages, and also about who's consenting to some of the anti-craving. So, I mean, it's an interesting system, which I think we should be approaching capacity, consent around treatment, and that might include the prescribed anti-craving medicines. That might include substituting with dealcoholized beverages. That's a treatment as well. But I think we should be approaching it the same way, right? If we see a patient that is at risk and we feel they're not capable, you know, in Canada, there's this test of understand and appreciate appreciate, really meaning, understand the impact in their own circumstances. If they're not, then we, I think, should be getting substitute consent and making those changes. And if it's a person with cognitive impairment, it may not be with their awareness of it. But I think we owe that to our patients, in my opinion. And many times I gave the example of someone wanting to live at home. It's aligned, with some of their values as well. And I'll just say one more thing about that. All of that said, again, and it could be perhaps seen as an example of ageism, many of the addictions programs, right, they require people to consent to their own admission to the program, whether it be a residential program or to any treatment changes. And that too is a bit of a difference to other ways, the way people navigate other aspects of health, right? Where they don't, where they may, if they're not capable, a substitute decision maker will assist in helping them engage. If someone's not capable but has a substance use disorder and they say, I don't want it, then help is not offered to them, which I think is a problem, at least, in many cases where we are in Ontario. Yeah.
Thank you.
Can I mention something about the de-alcoholized beverage? Is that, again, and this is something that I really, really push a lot with family members, because family members are told in AA meetings, family, family meetings for adult children of alcoholics, that you didn't cause it, you can't cure it, and you can't control it. But when someone has dementia, you are the substitute decision maker. You certainly have some control there, and it's a much easier and a kinder approach and more ethical approach to taper somebody rather than have them go through a very severe withdrawal. So using de-alcoholized beverage, and I use the example of Stella Artois. That's a it's a premium beer. It has the de-alcoholized version has this exact same branding as the regular beer. It's beer without the buzz, and so people don't have the effects of the alcohol. And so using that and switching that out with regular beer, once every 2 weeks, we were able to taper somebody off in a period of 3 months to 0 alcohol without a hospital admission. So it's I think a much more ethical and easier on the person, and the family has some element of control and are supporting their family members at home.
Yeah.
Rather than going to the emergency department for.
Thank you. Very flexible solution. The next question is from David Lee, and you can also see him. There he is.
David, yeah, it's a question about reversibility. I actually wasn't so sure of the recent evidence, so I did a bit of a search just seeing the question, and I saw a couple of things in terms of, we know that symptomatically and on cognitive testing, there can be some reversibility in a portion of abstainers. And I actually did see some one study, for example, that showed white matter volume actually increases in reversing some of the atrophy in abstinence. So there is a little bit of research in that regard. Thanks, David.
Thank you. And the last question is from Nicolaas Paul Verhoef. Can you please say something about tobacco smoking and the use of nicotine in older adults as cognitive enhancers? What are the treatment options and how effective are they? So tobacco.
So you're on mute, Marilyn. Oh, you're on mute, Marilyn.
There are some psychiatrists in the US that use nicotine as a cognitive enhancer, but I really can't, I don't have the data at the top of my head. But in terms of the smoking piece, it's the smoking part and the inhalation of the burnt tobacco, that's what's bad for you. The nicotine isn't. It's addictive, but it's not harmful. So I really can't comment on their research, but recall hearing that at last year's meeting, the geriatric psychiatry meeting in the US, that they were finding benefit from using nicotine for cognitive enhancers. But I can't say much more than that. But certainly
Okay.
with nicotine dependence for older adults, certainly you want to make sure that the person's nicotine withdrawal is mediated by using nicotine replacement.
Thank you. And I close the Q&A now, but not before thanking Marilyn and Chris for their excellent presentation. And there are many comments, compliments in the chat. We will save the chat, Christian, if possible. And it is exactly in time, so all questions are answered. I would special thanks to all those who posed questions, really great questions that guided our presentation. And I want to thank Christian and Maria and Rob for the organization. Our next webinar is in October 16. The theme will be loneliness in later life, and the speakers will be Diego de Leo and David Kohn. And before ending this, I really want to ask you to fill in the evaluation form and also take the opportunity to ask about future topics. So many of our webinars have been made around the topics that were asked by the participants. There are some, you are now watching some upcoming events, and well, the big event is, of course, our conference. Thank you very much for joining and for participating. Thanks, and I hope to see you again next time. Bye.